like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.
Great. Well, thank you so much, Dr. Zell, for inviting me and MOASC. This is actually a wonderful location. When I got here, which I live way out in Moreno Valley, I was like, wow, this is like 20 degrees cooler here. So it's a much nicer place. So thank you again for inviting me, and I just want to kind of give you an update in terms of pancreatic cancer. And unfortunately, pancreatic cancer is not the new non-small cell lung cancer, but we are getting there. So pancreatic cancer still has the worst survival of any solid tumor. In 2023, it's estimated about 64,000 cases with 60,000 deaths. And unless we actually really have a significant improvement in terms of our treatment modalities, by 2030, this will be the second leading cause of cancer-related death behind lung cancer. Now, why is it that pancreatic cancer is so difficult to treat? Well, number one, a majority of the patients that get diagnosed with pancreatic cancer are diagnosed in the metastatic or locally advanced setting. Only about 20 to 25% of patients are actually surgically resectable. But you can see on the bottom right-hand side, we are making progress because over the last 10 years or so, we've actually doubled the 5-year overall survival rate in pancreatic cancer. So what I really wanted to kind of focus on is two abstracts. One is the NORPAC trial, and I really wanted to kind of give you my take on neoadjuvant therapy because this is something that's really been evolving over the last decade. About 10 years ago, when we had the approval of FOLFIRINOX chemotherapy as well as gemcitabine and nab-paclitaxel, there was actually a big shift to neoadjuvant therapy. Prior to that, pretty much all patients were going to surgical resection if they're a surgical candidate because our systemic treatment options really had, very low response rates. Gemcitabine had about a 5% response rate. So when we actually had better chemotherapy regimens, there was actually a shift for even surgically resectable cases to actually go to neoadjuvant therapy. Now, the rationale behind that is, of course, pancreatic cancer is a very aggressive disease. There's micrometastatic disease that leads to, of course, distant failures. And after surgical resection, it's really difficult to tolerate chemotherapy because they have a lot of GI issues. There have been some clinical trials retrospectively looking at neoadjuvant therapy, and what they showed was that giving neoadjuvant therapy, they're able to complete their treatment prior to surgical resection, and then they would actually go on to surgical resection. And there was some retrospective data that actually showed good survival, results with neoadjuvant therapy. Now, when you look at the NCCN guidelines, it doesn't really kind of give you as much guidance as you would hope it would. For patients with resectable disease, you can see here that pretty much it's really kind of dealer's choice. You could either proceed to surgery without neoadjuvant therapy, proceed to neoadjuvant therapy, and when you actually look at all the little different subheadings, it pretty much basically gives you the spectrum of giving 3 months of chemotherapy before, 3 months of chemotherapy after, 6 months of chemotherapy before, chemoradiation. It kind of gives you the whole gamut of whatever you would like to do. So I really want to kind of give you my take in terms of neoadjuvant therapy for pancreatic cancer based upon the data. So this is actually a very good trial that was actually done by Devendra Sohal and SWOG, and this is the 1505 trial. Now, what this was actually looking at was that this was actually looking at patients with surgically resectable disease to get 3 months of FOLFIRINOX chemotherapy or gemcitabine nab-paclitaxel chemotherapy, undergo surgical resection, followed by 3 additional months of chemotherapy. And initially, when they were doing this clinical trial, it was actually very challenging because a lot of the patients that were getting enrolled are the ones that, of course, we automatically give neoadjuvant therapy to, the patients that are borderline resectable, locally advanced. They had to implement central radiology review for this clinical trial to make sure that these patients were surgically resectable. Now, what I wanted to kind of point out at the bottom here, when they looked at the median overall survival for both groups, it was actually very similar, 23.6 months and 23.2 months. Now, for me, when I actually heard the results of this clinical trials, I was sitting there scratching my head. It's like, well, we're giving neoadjuvant therapy for surgically resectable disease, and we have a median overall survival of only about 23 months. When you look at the adjuvant clinical trials for patients that undergo surgical resection, this is the CONCO-1 trial looking at gemcitabine versus surgery alone. Median overall survival, 22 versus 20 months. Gemcitabine, capecitabine from aspect 4, 28 versus 25.5 months. And of course, with modern day FOLFIRINOX chemotherapy given for 6 months after surgical resection, we're talking about 54.4 months versus 35 months. So this made me, think a little bit. It's like, well, if you have a patient with surgically resectable disease and they go on to adjuvant chemotherapy, why is it that they do so much better than if they got some perioperative chemotherapy? And my take on this is that basically, remember, we talked about pancreatic cancer being a micrometastatic disease. It spreads early. If you end up giving 3 months of chemotherapy with a regimen that only has about a 32% response rate, and then you have to end up stopping your therapy for at least a month to 6 weeks before they go into surgical resection, that probably allows some time to actually have, distant spread during that period of time, and then they would actually end up potentially having progression after they end up completing their therapy. So in my view, for the cases that were really surgically resectable, then you would actually want to go ahead and take them to surgical resection, unless they have, of course, high-risk features we'll talk about. So this was the NORPAC trial. So this was actually 12 Nordic countries where they actually looked at a randomized phase 2 study to actually evaluate upfront surgery followed by adjuvant chemotherapy versus giving FOLFIRINOX chemotherapy initially, followed by surgical resection, followed by the completion of their adjuvant therapy. Now, again, there's some criticisms just because they gave a very short course of chemotherapy prior to surgical resection. Right now, we commonly give a much longer course of chemotherapy prior to surgical resection. And the primary endpoint here was overall survival. And what they wanted to do was they wanted to actually evaluate whether or not neoadjuvant therapy could actually increase the survival rate from 50% to 70%. What they saw was the median overall survival was 25.1 months with neoadjuvant therapy versus 38.5 months with upfront surgery. So in my view here, again, this is patients with surgically resectable disease. And, for me, the patients that are surgically resectable are the ones that don't have any vascular involvement, so they don't have any distortion of the venous system. They don't have any arterial involvement. You'd want to take them to surgical resection. For the ones that, of course, that do have vascular involvement or have any type of borderline resectable disease, this is the SPEC-5F trial where they actually looked at borderline resectable pancreatic cancer cases to get either immediate surgery, gemcitabine, capecitabine, FOLFIRINOX, or chemoradiation therapy. And here you can see that the FOLFIRINOX arm, which is the one in green, was actually doing much better compared to the ones that went to immediate surgery. So this is actually our standard practice, is that for patients with borderline resectable disease, you'd want to actually give them neoadjuvant therapy. And my personal feeling is that I tend to give them total neoadjuvant therapy because I want to be able to actually give them the maximal response to chemotherapy prior to going on to surgical resection. So key points for resectable disease without high-risk features, surgery remains the first line of treatment, and then they get adjuvant chemotherapy with FOLFIRINOX based upon the PRODIGE trial. If they do have high-risk features like bulky lymphadenopathy, really high CA19-9, or vascular involvement, then of course you'd want to give them neoadjuvant chemotherapy. We did see, of course, that after surgical resection, it is very challenging to give chemotherapy, so this is why I'm leaning more toward total neoadjuvant. And again, neoadjuvant therapy is the treatment of choice for borderline resectable disease. So moving on to advanced pancreatic cancer, this is just to kind of give you a refresher course that, our typical standard first-line treatment is either gemcitabine, nab-paclitaxel based upon the IMPACT trial, or FOLFIRINOX chemotherapy. So you see an improvement in median overall survival from 5.5 up to 8.5 months with the gemcitabine, nab-paclitaxel regimen, and an improvement of 6.8 months up to 11.1 months with FOLFIRINOX chemotherapy. So this year, the NAPOLI-3 clinical trial was presented, first by Dr. Zev Wayne-Berg at ASCO GI, and Eileen O'Reilly actually gave the update of the 12-month and 18-month data. This was a randomized phase 3 clinical trial of the regimen NALIRIFOX versus gemcitabine and nab-paclitaxel. What I wanted to point out here are the chemotherapy doses that were given in NALIRIFOX. Liposomal irinotecan is normally at 70 milligrams per meter squared. Here it was actually dose reduced at 50 milligrams per meter squared. Oxaliplatin in the normal FOLFIRINOX regimen is normally 85 milligrams per meter squared. Here it's actually 60 milligrams per meter squared. So that's really important because one of the challenges we always have with chemotherapy is the toxicities of the chemotherapy regimen. Many patients, when we give them chemotherapy, some of them just have, unfortunately, too much toxicities to really get the benefit of the chemotherapy. So in this particular regimen, they actually went ahead and dose reduced the chemotherapy compared to the original ProDig regimen. So the primary endpoint was overall survival, with secondary endpoints looking at progression-free survival, overall response rate, and they also looked at health-related quality of life as well as biomarker assessments. So with the dose reductions, what were the adverse events seen on the NAPOLI-3 trial? As we would expect, gemcitabine nab-paclitaxel chemotherapy had significantly more hematological toxicities, and then for NALIRIFOX, they had more GI toxicities. Now, I want to just kind of point out a couple of the key side effects. So if we look at neutropenia, for NALIRIFOX, it was about 23.8% versus 38% for the gemcitabine nab-paclitaxel. When you go back to the original ProDig trial, the neutropenia rate for grade 3 to 4 is up to 45.7%. And again, this is, a much more aggressive regimen because this is without the dose reductions that we commonly utilize today. What about diarrhea? Diarrhea was, of course, more in the NALIRIFOX regimen compared to gemcitabine nab-paclitaxel. And looking at the ProDig regimen, about 12.7%. So the NALIRIFOX regimen actually had more diarrhea compared to the original FOLFIRINOX regimen. And as far as neuropathy, there was actually less neuropathy with the NALIRIFOX compared to gemcitabine nab-paclitaxel, and about 9% with the original FOLFIRINOX regimen. So by giving the dose reductions, there was a decrease in terms of the side effect profile with the NALIRIFOX, and I think that is what actually allows it to be a little bit better tolerated. So these are the Kaplan-Meier curves and the results for the NALIRIFOX regimen. It did meet its primary endpoint of improving overall survival from 9.2 to 11.1 months. Progression-free survival was also improved from 5.6 to 7.4 months. So the initial dose reductions did help to decrease the toxicities. Unfortunately, we don't have any head-to-head comparison, though. So many of us commonly give FOLFIRINOX chemotherapy, and we will actually go ahead and dose reduce the irinotecan as well as potentially the oxaliplatin. And there is no head-to-head comparison to see whether or not NALIRIFOX is actually better than modified FOLFIRINOX. But this is actually a good trial because of the fact that this actually looked at a standard regimen of gemcitabine nab-paclitaxel, and it demonstrated that the 4-drug regimen is superior to the 2-drug regimen. So commonly for a majority of my patients that I see that have good performance status patients, they will be getting a modified FOLFIRINOX regimen to start off with. Now, I wanted to kind of end here to talk a little bit about, we heard earlier today that, biliary cancers are becoming the new non-small cell lung cancer. Well, pancreatic cancer is moving that way, and I think that's what's really made improvements in survival for our pancreatic cancer patients. But I wanted to just kind of present some of the data that kind of led to this. So if you look at the NCCN guidelines in terms of the diagnosis of pancreatic cancer, if you do have the diagnosis made, you do want to actually do germline testing. Now, I still commonly see many patients that come to my clinic that, unfortunately, they do not get germline testing. And when you're actually doing germline testing, you'll detect about 5 to 7% of patients that will have a BRCA1 mutation that does impact their care down the road. If you have metastatic disease, of course, you want to do molecular profiling of the tumor. And this has really, I think, made an impact in terms of targeted therapies for our patients, and that's what's really helped to impact survival. Now, this is a study that was actually published by the Memorial Sloan Kettering Group, where they actually looked at early onset pancreatic cancer. And for 2008 to 2018, they actually looked at the 450 patients that had early onset pancreatic cancer. What they found was that BRCA1 and BRCA2, as well as PALB2, consisted of the majority of the pathogenic variants identified. And we've seen, of course, with Eileen O'Reilly's data, that platinum-based chemotherapy had a significantly higher response rate with the BRCA1, BRCA2, as well as PALB2, with actually some patients achieving near complete pathologic response. Now, what was also really interesting is that this is the population of patients that you really want to pay attention to the molecular profile, because what they saw was about 15.9% had RAS wild type. A majority, most of the patients overall have KRAS mutations, but in this group of younger patients, they did have RAS wild type. And these are the ones that you're finding the MMR deficient pancreas cancer, tract fusions, IDH, as well as other very highly actionable mutations. So you want to pay attention, especially to the younger patients, do genomic profiling, get that done early on, because you're looking for these types of molecular alterations that really have a significant impact in terms of their treatment. And this is, of course, work that was done through the Pancreatic Cancer Action Network, where patients were molecularly profiled, and they were actually matched to their therapy based upon the molecular profile. And this is just showing that matched therapy did improve overall survival, and it was actually statistically significant. So in conclusion, we are making progress. It's been very slow progress. It's been about 10 years since the last regimen that was actually approved back in 2010, 2014 with FOLFIRINOX and gemabraxane. But NALIRIFOX is a regimen that is, of course, shown in the NAPOLI-3 trial to improve overall survival. I think the question here is, of course, there is a significant cost associated with NALIRIFOX regimen, and we currently do not have head-to-head data with NALIRIFOX as well as modified FOLFIRINOX. So for resectable pancreatic cancer without high risk for features, I do think surgery first, followed by adjuvant therapy. For borderline resectable pancreatic cancer, total neoadjuvant therapy. And I think a big question mark here is the role for chemoradiation. For a majority of my patients, I do favor a 4-drug regimen, and I think that is actually, commonly seen today, that many patients are getting 4-drug regimens off the bat. And all patients should undergo germline testing as well as somatic mutation testing. And I think that as we actually are able to do that with more of our patients, we will start finding more actionable mutations, which is going to impact survival. So I'd like to thank you for your attention, and I'd be happy to take any questions.
Like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.